Hi, I'm Dr. Gerald Deas. Welcome to Health Center from Downstate Medical Center. Today we're going to talk about babies. Babies. I know you all have had babies, or many of you out there have had babies, sometimes sick babies. You know, when the cold weather comes in, when a child has asthma or any kind of convulsion or anything like that, and they're very ill, they have to get to the hospital. Now, you would think that when they get to the hospital that they would just go into a regular ward, but we have a particular ward here at Downstate Medical Center for critical ill babies. And that has to be taken care of by physicians who are trained in that. And that takes more training than just like I'm in internal medicine, or that person's in pediatrics. And they have special training because even the little arms, to put an IV in here, or any of these little things, or the way you lay the baby and so forth. But we're going to also talk about another thing, is that babies who are hurt by parents sometimes, or lovers or things like that, and they shake the baby like this here. Just shaking the baby like this here. You don't know what it's doing to the brain, or to the neck, or to the bones all around the neck and things like this. So we want you to listen today and see very carefully if you have a child that's sick. And here at Downstate Medical Center, we have this kind of service that we can take care of very small babies, much smaller even than this, almost the size of my hand when you think of it sometime. And they have to stay in the hospital sometime 2 and 3 months after birth and so forth. And today we have Dr. Francine Olds. She's the expert in critical care for babies here at our Downstate Medical Center. I want to welcome you, Dr. Olds.
Oh, thank you for having me.
It's nice having you here. You know, Dr. Olds, I see you walking around with your, in the wards there with these critical babies and things like this, and I say, that must be some specialty when you have to take care of something that small. But before we get into that, just so the audience will understand who you are, where you came from, and what made you want to get into pediatrics, plus become a critical care doctor. Where were you born?
Okay, well, I was born in Southern Virginia.
Okay.
It's a little place outside of Lynchburg, Virginia.
Okay.
Very small place. You know, from there I did a lot of my schooling in Virginia. After high school, I went to the University of Virginia in Charlottesville, Virginia.
When you went to your undergraduate at Virginia University?
University of Virginia.
University of Virginia. What courses did you have to take? Did you take pre-med course, or what was that like?
Well, I took the pre-med courses because at that time I already knew I wanted to be a physician.
Right.
And I loved the sciences, so I decided to major in chemistry at that time.
Okay, right.
So,
and then from there, in taking many tests to get into medical school, what medical school did you ultimately get into? And I know that, you know, getting into medical school in those days, in fact, how many, what was the size of the class, for example, in medical school? What was the size class numbers of folks? How many people in your class about?
In my class, I went to the University of Maryland in Baltimore for medical school, and my entering class was about 145, 150 students.
I see. And among that, how many African Americans are?
It was probably about 20%, so maybe close to around 25, 30 students.
Right, right. And medical school, how many years you have to spend in medical school before you even go on further?
Medical school is 4 years of training. 2 years where you're just in the classroom, sitting and studying and taking notes, and then your last 2 years of the clinical science, where you're actually out there taking care of patients and learning how to take care of patients within the hospital.
And what made you think you wanted, you know, the first time I asked children, what do you want to be? They always say pediatrician. I'm talking about the small ones. Pediatrician. What made you want to be a pediatrician? I mean, you had all these fields you could choose from, but what made you think that you would like to be in that field?
Well, for me, it actually came down to pediatrics versus general surgery.
Okay.
And I know it was like two completely different fields, but I consider surgery because I love working with my hands and I love doing procedures.
I see.
But also realized that I like working with the kids more. And there was other ways that I can work with my hands without going into surgery, so I chose pediatrics.
That's wonderful. Now, when you were a little girl, did you ever say that you wanted to be a pediatrician, like all the little girls I see say this? Or did you have that even in your mind, in a sense?
You know, I think At some point I wanted to be a doctor because I loved how the body worked and how it moved. I don't know if I ever said I wanted to be a pediatrician until I got into medical school.
Right.
So for me, I think it was just always first wanting to be a doctor, and that just kind of fell into place later on.
That's one. Do you come from a small family, a large family?
I myself just have one sister.
I see, right.
But I had lots of aunts, uncles, cousins. So.
Right. Now, entering into medical school, did you find it difficult?
It's a level of work that you don't really expect. You know it's going to be a lot of work, but you don't expect that much work. But it is difficult. But it's something I wanted, so I, was up for the challenge.
And you had to give up a whole lot of social life, I bet. Or did you? Or did you kind of even it out, at least with some social things? And so
well, I think you have to take breaks,
right.
or else you're going to, go crazy trying to study, all day, every day.
Right.
But there are things that you do have to give up. Some activities you have to give up. But it's for, your future. So giving up a little bit of time here versus, what you really want to go into and what you love doing, it's worth it.
Did you do any volunteer work while you're in school or out of school and so forth?
Undergraduate, I did some volunteer work. In medical school, you don't really have that much time to do it. But after that, try to, when you can. Schedules sometimes don't allow you to do it, especially now. But I do still try to get stuff in.
Well, because I know a lot of students might be looking at this now from high schools or college. And here we have Dr. Olds here. Just like I am, they would say, and if she can do it, maybe I could do it too, And so what would you suggest for those students who might be looking at you as a doctor now to concentrate on, particularly from high school to college and things like this?
I think going in from high school to college, I think making sure you develop good study habits. That if you already have good ones, make sure you keep those study habits. But that's going to be very important if you want to go into the medical field, to be able to focus and learn and move forward. But also you have to be well-rounded. So you got to be able to volunteer. You have to do some research. Community service is important. Clinical shadowing. So going out, if you want to go into medicine, you got to be able to shadow a doctor or in a hospital, or you can follow somebody in their clinic. So those are three major things that are important that you got to have outside of the academic work.
Right.
So
now, is there any one doctor as you were coming along in life that impressed you or kind of encouraged you, or in any way you looked up to, say, I want to be a doctor for real?
I think growing up, I did not have a lot of doctors to look up to. In the area that I grew up in, I didn't really see any doctors that looked like me. So I don't think I had that. But, there were always people around who encouraged me. I mean, I remember undergraduate, it was my physical chemistry professor who encouraged me to keep going. So there's different people along the way. And, thank God I listened to those people because they had a better knowledge, better advice than I had at that time. And so,
well, I understand you, in fact, just telling me how even here at Downstate you want to be more involved in role modeling for our students, high school students that come past you, or the medical students. And I think that's admirable because, if you don't see it, you don't believe it, you know what I mean? And people have to see folks like yourself, or young doctors like yourself, to do this. In pediatrics, how long is the residency? Like after you finish medical school, how many years did you have to spend in residency? Residency means further training.
So after medical school, most of the specialties are 3 years. So pediatrics is 3 years. I think like internal medicine was usually 3 years also.
Well, my time was 4 years.
It was 4 years then. I think it's 3 years now. So it was just 3 years of training. So
did you have to take an internship though before they went in?
The first year of training is what you're called like an intern.
I see.
So you get through those 3 years and you're learning how to be a general pediatrician at that point. So.
And then finally, I imagine you saw all the fields that you could have gone in pediatrics, from surgery to any number of things, and you chose critical care. Had you been exposed to critical care of taking care of babies? You know, I'm talking about babies like I said, as big as my hand. Maybe you could describe how tiny those things are and to keep it alive.
Well, yeah, when you go through like your pediatric residency, you're exposed to pretty much everything. So there's the pediatric intensive care units. There's a newborn intensive care units.
Right.
The newborn intensive care unit is one where the very tiny babies, you know, that are born premature,
Right.
as early as like 25 weeks, sometimes 24 weeks
Wow.
early, or babies that are born with, you know, serious problems. And so those are babies that will go there.
I see.
I actually do the pediatric critical care, so we take care of babies that are from birth, normal, you know, term
Yes, right.
babies, all the way up to here up to 21 years of age.
Right, right.
So some places may go up to 18, we go up to 21 years old.
I see. Now, those children who come in critical care, what are some of the usual things bring them into critical care? They're home, the baby's sick, they bring them to the hospital. What are some of the conditions do you see? Or is it too early or too late when you even bring a child into critical care?
Well, I think in pediatrics, we tend to see a lot of respiratory illnesses. So things like asthma, kids who come in very sick with asthma, they're having a lot of trouble breathing. We have kids that come in with bad pneumonias. And some of these kids will end up on a ventilator and need to have a ventilator help them breathe. We see kids that come in with bacteria infections in their blood, bacteria infections in their urine, or they can have other traumas. And another thing that we see and take care of. Neurologic problems, so if there's bleeding in the head or some other type of trauma that may have caused it. So we see a wide range of things from, you know, like I said, respiratory to the kidney failures. We do a lot of dialysis within our unit for kids that are very sick on dialysis, to, you know, infections, to anything can really come in that we have to be prepared to take care of.
And I imagine it's very intense work, and you become attached to these little ones too, I imagine.
Yeah, you do become attached, but you have to somehow learn to kind of be attached but not be attached. So to not get so involved that you're carrying kind of like all of their burdens on you, because that will kind of burn you out early in this field because it is so intense.
Right.
So.
Now, when you're on, say, a particular time of the day or night and so forth, does your time run into 24 hours sometime, or is it sometimes you say, I'm going to do 8 hours and leave?
It kind of depends on my schedule. So like weeks that I'm on service, meaning on service where I come in the mornings, I round on the patients with the residents, and we have physician assistants in a unit, and we have medical students sometimes. So we go around all of the patients and we do our rounds in the morning. And then throughout the rest of the day, you're kind of busy tweaking things, or you get new admissions. So you're maybe adjusting the ventilator, or adjusting medications, or, you know, admitting a new patient to the unit and getting them settled in. So you're kind of busy throughout the day. That's during the day. And then we have night call. Now here at Downstate, there's 3 of us, so we kind of split up the calls.
I see.
So sometimes you're on call at night and you have a good night. Last night I was on call and you know, got enough sleep. So, and then there's nights where you
up all night
and you're staying in the hospital all night trying to help, you know, stabilize a child, or keeping the child alive. So you have those nights, and we also have to work a few, you know, weekends, you know, 1 or 2 weekends a month. So it is a little bit busier than some other of the specialties, but you know, this is what I enjoy. So,
well, now I imagine when a parent comes in and brings that baby in, you see the distress all over their face, you know, that they're losing this child. They might have children at home and they have to get back home too. And but I imagine when they finally come at the end of how many weeks usually does a baby stay in critical care, the average time?
You know, the average time is hard to say. I would, you know, because it kind of depends on how sick the child is and what they're coming in for. You know, they can come in for a severe asthma attack and be there for 3 days, or they can be there for a week and a half. They can come in for something else and be there for a month. or longer.
Right,
So,
yeah.
or some come for a day or two. So it kind of varies and depends on what their needs are.
I bet it's so much pressure on you, though, when the parents comes in to see the child, they're looking at you as the savior of this child. And if it doesn't happen, they'll be disappointed. So I imagine these kind of relationships you have with a parent must be very tense sometimes from the standpoint of, how's my child? It doesn't look good today. What's happening, this thing and that thing. You know, it's amazing how then all the family starts coming in talking to the doctor. Mm-hmm. What would you suggest when a family has a person in that critical care who they should relate to? Because uncles will come in, or sisters and things like this. Do you have a set pattern that you tell the family who you will respond to?
I think most of the time we respond just to the parents.
Okay.
If the parents give us permission, or they want, like maybe there's a person that knows, maybe is already in the medical field that they want us to talk to,
right, yeah.
then they'll give us permission to talk to that certain family member.
Right.
Most of the time, though, it is, you know, the mother or the father. And we try to not give out all the information unless they give us permission to.
I see.
Because then it can get a little complicated, and especially if it's a very critical situation.
Yeah.
So you just want to, and you know, you give out information to one person, it kind of gets turned around a little bit, and
That's
things
right,
can get
surely,
confused
surely.
and mixed up. So you just want to try to deal with the immediate family.
Right. But I just look at yourself, and I just look at your face and things like this. It must be comforting to have a doctor like yourself to talk to a family, because some doctors can be very cold, you know?
Yeah, a little.
And you can't learn sometimes how to embrace people unless it's in you, you know what I mean? And when a baby, particularly a baby, is sick, that whole thing has to be so like you're the angel, you know what I mean? And they're expecting you to move that thing no matter what. Do you get disappointed sometime, or do families get angry sometime because they're not responding the way that you think they should, but they're getting the best of care?
I mean, I think what I can do is the best that I can, but also trying to be honest and open with the family and let them know up front, you know, this is what we expect. This is what's happening, and try to, you know, always kind of reinforce that as you go.
Right.
Because there are so many emotions that go on, and, you know, a family's going to get angry, and I understand that, you know, that's part of the whole process that they're going through, or they don't like how something is going. You know, we're humans, you know.
That's right.
And sometimes we have to put ourselves in their shoes and kind of look at, see what they're going through.
That's
so
right.
there's a lot of things. I mean, the caring is there. What you can learn, though, is how to better communicate with families. And so I think that's a learned quality. And as I'm going up through my career, I'm still early in my career, I'm learning how to better interact and communicate, you know, bad news or good news, or, you know, to families. So there's always, I say, room for improvement in talking with families. But that,
you know, I think sometimes in medical school they miss that, teaching students that, you know, because 4 years in medical school don't make you a doctor.
No.
You know? And a doctor, the word doctor means to teach. That's what the word doctor means. But when you become a physician, that takes doctoring in, it takes humanity in, it takes religion in. Do you ever pray?
all the time. Some pray before, you know, do a procedure, pray, you know, for the families, yeah. And the patients.
And I think sometimes when this comes across and you're talking with our family, that brings you closer in. Don't you think so, when you mention even prayer or something like that?
I mean, I've had families ask me to join in with their prayers over their child, and that's fine. I don't, you know, so I think, you know, in my life, that's an important part. And so hopefully families will see that as, you know, as I'm interacting with them.
Well, I know that in my own practice, I had to interact so much with so many families and things for 42 years that I don't even know sometimes how I got through the crisis of it. You know, somebody dying suddenly, and it wasn't your fault by any means, you know. But at the same time, people can die. They can die in critical care, you know. And when that death takes place, just to get on the phone to call a person, the family in, that the baby's not doing well or the baby looks like it's not responding well, that must take a certain amount of energy and courage to do.
Yeah, it's not easy. It's
No.
not easy.
I
Again,
think
I think you learn how to handle that better as you go throughout your career, but it's
Right.
definitely each time it's still not easy.
That's right.
Yeah.
Because certainly when you're there at the hospital and the family walks in and you have this news that the baby has expired or something like that, I can imagine. You know, we all are human. Doctors are human. It takes a lot out of us when that happens. You know?
Yeah, it is, and you know, I tell people like to be in this field in critical care, whether it's pediatrics or adult, you have to be able to handle like death and dying issues.
Oh yeah.
Because we see a lot of it.
Yeah.
And if you can't handle that, you know, that's fine. You know, maybe there's something else that's meant for you.
Surely.
So, but there's so many opportunities out there, though.
Sure.
But yeah, it is tough to deal with that, and you got to find your own way to handle it so that you don't get burnt out.
Right. Sometimes I look at the film from Haiti recently and think of the babies that were lost there, you know?
Yeah.
And they didn't have critical care, you know, and things like this. You just
They
wonder.
barely had the basics there.
They didn't have the basics, you know what I mean? And so we're so blessed, you know, to have this in a country like this, but yet babies still die, you know, with the best of care even, you know.
Right.
But when you think of the floods and things that are taking place right now in Mexico and all these different kind of places and things like this, and you see children dying, that is very hard on parents. Or in Africa,
Right.
you know, babies sitting on a breast with no milk coming out of a breast and things like that. You know, it must be something. And getting this little guy here, you know, the other thing I maybe wanted you to demonstrate is what happens when somebody gets angry with the baby and they start shaking it like this here. They start shaking it. You know, what's the matter? Why are you crying and so forth and so. So, what's going on in that baby when that's happening?
Well, I think, you know, one thing, babies, you know, are small. They're, you know, not just little adults. They're infants. They're small. They're not as strong as we are.
Right.
They don't have the head control that we have. Their muscles and ligaments aren't as strong as like we can control our head. So when you're doing that, you know, when you're shaking a baby like this, or somebody's getting really mad, you know, that the head is going back and forth and back and forth.
Sure.
So, and also, you know, yeah, we have a skull, but within here is a brain that's also hitting the back and, you know,
With a
front
lot
of
of blood
the
vessels.
skull. So
Yeah.
inside, blood vessels are tearing and bleeding can happen.
Yeah,
and
right.
and when you start getting blood and swelling in the brain, just like if you have a cut and it swells and it gets all red around it, and you know, the brain, same thing, can swell and bleeding around it, and that pressure in the brain can cause a lot of damage. And
Right,
also
yes.
the bleeding in the brain can cause a lot of damage and cause even death in
Right,
babies.
yes.
What they call like shaken baby syndrome,
Yes, right.
or child abuse, you know, if you want to
Yeah.
put it
And
like
you know,
that.
it seems like in our communities, is with the people that are depressed, jobless, angry, it's very easy to get angry with something that you even love.
Yeah.
You know?
I think some people take it out on the child.
Yeah.
Um,
And I think that around this time, I know in the WIC program and all these kind of things, where the families here are carried through from the pregnancy all the way through the birth of the baby, they almost have to be given classes how to handle pressures, you know, especially when they take that precious baby home. That baby's alone, you know, and in that house by itself, and that mother might not have enough money for just to get food.
or
and
not
things
enough
like that.
support.
Yeah, don't have support of anything.
And you're tired, and there's a baby that's crying all night, a new baby. You know?
Yeah.
So there's a lot of stresses with a new infant in the home.
Yeah.
So,
And when you think about birthing today, they give them maybe a couple of days and they're out with that baby, right?
Yeah, like,
Yeah.
was it 2 days, 48 hours or so?
Right.
Yeah.
Well, I tell you, with this little one here, I'm sure he could be a happy child and enjoy the family and enjoy all his relatives, enjoy doctors such as you to take care of them. If I do get sick, you will take care of me. I know, and I'll feel quite safe under your care. I tell you, Dr. Olds, it's so nice having you here today.
Oh,
Time
thank
goes
you.
by so fast, but at the same time, I really wanted to let folks know at Downstate Medical Center we have a service called Critical care, you know, and you're one of the critical care doctors who's an expert in the thing, and that when something happens and it's not your doctor's fault, don't take it out on the doctor, because the doctor has done all they can do, you know, and they're not God, you know, and things like this. So just one last word from you. I hope you stay in critical care. You plan on staying in critical care?
Yeah, I can't see myself doing anything else.
Right. Well, I'll tell you, I'm so glad to have a person like yourself on this staff here that can relate to them. And to you folks out there, your babies can do well here at Downstate or any other of the hospitals where they have critical care. It's not for you to go in and raise Cain with the doctors and say they're not doing their work. Not one doctor wants a patient to die. We never want to see a patient to die, whether it's small or big or what have you. So never take it out on the doctor to think that they haven't been given the best. And Dr. Olds here has been here for a few years now, and she's one of those doctors that will give you that kind of care. And to all you young people out there, if you want to be a Dr. Olds, study hard. I'll see you the next time.